Dr. Lasky, members of the Advisory Committee, Zuckerman, members of the FDA. I'm Jody Aiken. I'm the Vice President of Global Affairs for Edwards Life Science. It is my pleasure to be here to discuss the Edwards SAPIEN transfer valve system. SAPIEN valve is a product of many years of development and expertise in aesthetic heart valve technology. The bovine pericardial plits, which are specially treated by calcification, are onto a balloon expandable steel frame. Path to approval for the first indicate 10-year process. In 2002, the first valve was implanted in man. Feasibility studies were completed in 2006. Of these studies led to a great collaboration with specialties and FDA, development of the partner trial design, subsequent IDE approval in 2007, at which enrollment in partner began. Enrollment was completed in 2000. The trial was a two-cohort with two individual populations and two separate PMA after approval. Before allocation into cohorts, considered for enrollment if they were diagnosed with severe symptomatic aortic stenosis of the aortic valve. Patients were considered to be operable, were included in the high-risk operable. If they were to have mortality or severity of greater than 50% surgical aortic valve replacement, they were included in the inoperable cohort. The application for the inoperable indication held in October 2010. Edwards presented data cohort at an FDA advisory last July, and the indication was approved last year. We've already a post-approval study for the patient. The exact language of the indication operable cohort is seen here. SAPIEN was approved femoral delivery in patients with severe symptomatic native stenosis who were determined by a cardiac surgeon to be for open aortic valve replacement whom existing comorbidities preclude the expected benefit of the aortic stenosis. The PMA for the cohort was submitted to FDA in 2011 and as we will review today. As I previously mentioned, patients in this cohort have met eligibility for high-risk surgical candidate. After meeting this main eligibility criteria, patient further assessment to which delivery access stratum most suitable based upon considerations. If the patient had suitable arterial access, they were to a transfemoral strata and one-to-one between TAV and AVR. However, the patient was not a candidate for transfemoral access. For example, if the patient had tortuous or heavy vessels, they were to the transapical strata in a one-to-one fashion. The trial was designed to at least 200 transfemoral and 100 trans implants in order to provide full information for both types of access. These minimums, 492 transfemoral and 7 transapical patients randomized for a total of 99 patients enrolled in the surgical cohort. Per the study protocol and a prior statistical analysis plan, AVR population, including transfemoral and angle as a whole, is the corresponding control AVR population as a whole. The primary of the trial was all-cause mortality at 1 year. The fact that there is a highly effective and well-characterized gold comparator available, which is surgical valve replacement, superiority trial design, selected success margin of 0.5 percentage points upon with FDA. Partner is the file comparing conventional surgical aortic valve replacement to alternative therapy for patients with severe stenosis. The randomization of the partner trial in and of itself is a large cardiovascular device. A large non-randomized data set has been analyzed and will be presented. Chart puts into context the high-risk surgical cohort. The 699 patients in the randomization of the trial are joined by 1,800 consecutive enrolled non-randomized patients from September 2009 to January 2012 for continued access protocol. In total, we had more than 1,000 patients transfemoral and transapical. It's important to note that a consistent protocol and oversight, ascertainment and independent of key clinical events, monitoring, echo, and quality of life core lab was used throughout the study without any changes in the data monitoring board, clinical events, or executive committee membership. We will say that the continued access protocol fully support the results of the partner. These data, we request to expand indication for patients classified for surgery, including apical delivery approach, in who do not have transfemoral access. Information in mind, I would like to agenda and introduce our speaker presentation. Craig Smith, Chairman, Surgery from Columbia University Center, will discuss the need for TAVR option patients at high risk for surgical AVR. Dr. Martin Leon, Center of Interventional Therapy at Columbia University Center, will discuss the design and results. Dr. Smith and Leon, co-principal investigators in the trial. I will return to review Edwards Global ongoing studies approval plans. Wood, Corporate Vice President of Aortic Valve Replacement from Edwards, will discuss our company's commitment training. And Dr. will return for concluding remarks. In addition to we have invited subject matter experts seen here today to assist us in answering your questions. Thank you for your attention. I would now like Dr. Smith to the lectern.